Thank you for the lovely introduction and for MRA to inviting me to share with you some of our experience. None of the work that we're doing could be done without all of your partnership. And so these are my financial disclosure, and they're not relevant for today's presentation. But I have presentation disclosure, so we'll be discussing side effects, and I know side effects are scary. But what I want you to remember, we're going to be talking about immune checkpoint inhibitor therapy, which is now standard of care. This is a good news story. You should not be afraid of these drugs, despite the scary side effects we're going to be talking about today. As it was shown by Dr. Beta Warner, these drugs have bent the survival curves and give new hope to you all. And so today's goal is to increase your awareness about these side effects and tell you a little bit more about why they're coming around, and what type of work we're doing to solution. Also, disclosure, I'm a PhD scientist who works with physicians. And so I can answer some questions, but I am not a physician. So what I'm going to do today is tell you a little bit about the drug mechanisms. We're going to talk about these clinical presentations, how we're dealing with this in patient care. I want to tell you about what we set up at Mass General Hospital, where I work, how we bridge between the clinic and the lab to try to find solutions to improve patient care, and tell you a bit about the research program we've set up, in part thanks to the generous supports from this partnership between BMS and MRA that had funded my work. I want to start with this slide here to remind you that a lot of the work that helped fuel the development of these checkpoints was awarded in 2018, a Nobel Prize of Medicine, and it's recent work, right? We're going faster and faster with these discoveries. There's a lot of reason to be hopeful. And so for you to understand why we're dealing with side effects, I think it's helpful to understand a little bit the mechanisms of these drugs, and I'll try to keep it as high level as possible. So this whole concept of blocking certain pathways that unleash the abilities of your fighters, we're going to talk about these T cells, to attack and kill the tumors. It's different from other type of therapy because we're not targeting something that's specific to your tumor. It doesn't matter what's encoding the genetics of your tumor. Our host immune response is shared across all patients. And so this became this principle of unleashing the brakes from these T cells we're going to talk about, became the foundations for these drugs that targets this pathway that we call immune checkpoint inhibitor therapy. So I have a few cartoons, bear with me, and because I'm trying to keep it high level. So there's, you have an army, right? Different type of immune cells in your body that are there to protect and fight for you. Some of them, let's see if this mouse works. Beautiful. So these are examples of antigen presenting cells. Obviously, that's not how they look. They survey your body to identify potential threats, signs of threats. They're called antigens. And then when they find them, they go to your nearest lymph node and present them to your fighters. Their fighters are called the T cells. And they present the antigens to the T cells. And if your T cells recognize them as an actual threat, then they get activated, get the go button. And then as they get activated, they can multiply from an army and go circulate throughout your body to try to figure out where are the cells that express this threat, which could be your cancer cells, and then attack and kill. But you can imagine that if you have a whole army that's activated and just fighting all around, it can have long-term damage for your whole body outside having to deal with cancer. So our body has evolved some amazing mechanisms. They're called checkpoint. There's these molecules in your body that can be turned on your T cells or your fighters to say, enough with the fighting. We're back to normal. And so these checkpoints are like brakes, and there's different types of checkpoints. They put the brake on immune response. And these are really important because you need to slow down your immune response so that you don't damage other tissue. You also need to prevent your immune system from attacking your good tissue, right? These molecules are important to prevent autoimmunity so that your fighters can distinguish what is you, what is self, from what is bad, like a tumor, what is not self. You also need to prevent excessive response. Once a threat is released, that could be an allergen, or maybe you're fighting COVID, right, or an infection. And so the same fighters are fighting, but once you've cleared the threat, these fighters need to stop fighting against these molecules that come up. But the cancer cells are smart. They figure out that they could co-opt this mechanism. They can express the molecule that tells the T cells not to fight. The cancer cells basically tells your fighters, I am not bad, I'm a wound that needs to be repaired, right? These are mechanisms. So they present the molecules that blocks these checkpoint. And so going on, I promise this is my last cartoon, so this is small from here. If you're curious, you can go see this website. I thought they did a very good job. I cannot take credit for these cartoons. And so here you have your little T cells, you have your cancer cells. So the T cells, the antigen-presenting cells show the proof of what is a bad cell. And so the T cells can go around and recognize that, oh, you're a bad cell. But actually, if your cancer cells express, so the T cells would have PD-1, if the cancer cells has PD-L1, it can actually block this go button and then gets your T cells to go asleep and escape. Now, if you give checkpoint inhibitors, it's basically block that molecules on your T cells. And so when the cancer cell comes and tries to silence your T cells, it doesn't work. Then the T cells can do their job. There's different types of drugs, though. And so another drug can be targeting PD-L1. It actually targets what's on the cancer cell, not on the T cells. And it's the equivalent of putting bubble wrapping on the bed of the cancer cells. And then it cannot attack the T cells. And then the T cell can do its job. It's overly simplified, but it's the idea of releasing these breaks from these T cells so they can just go and attack your tumors, regardless of the genetic makeup of your tumor. And so there have been different approvals you've heard from previous speakers. I should add here, like 3, I should have definitely updated my slides here. But it's this idea of reestablishing the ability of your fighters, the T cells, to attack the tumor. It's a good news story because since 2011, when it was approved for melanoma, this group of drug has now been approved for 109 indications. And the goal here is not for you to read every little box, but to give you a sense of how much of a good story this is. And so you can imagine that now the goal, of course, is to improve efficacy. So what do? We push on combining therapy. You've seen this from Dr. Warner in previous talk, right? We're combining checkpoint inhibitors to increase response, and it's working. But now I told you how the role of these molecules, these checkpoints, in protecting yourself, your T cells from attacking tissue. So it shouldn't come as a surprise that as we push and combine more of these drugs to block these checkpoints, we're getting into problems of side effects. Depending on the dose, on the combination of treatment, up to 90% of cancer patients will develop side effects. It can affect any organs of the body, from simple skin rash to deadly heart inflammation. And you're seeing the incidence on the rise, so the most common one is rash. Myocarditis is in about 1% of patients. And I think sometimes it's just easier to see the scope of these side effects through a story. And I want to tell you the story about David, with full disclosure that this is not a good ending, but David was the inspiration of the whole program I'm going to tell you about. And we owe a lot to David in shaping our journey. So David was a successful businessman from Massachusetts, and his family allows us to tell his story. He was 64 years old, and he was initially diagnosed with melanoma with brain mets. He was a risk taker, and so at the time decided to go for combination therapy. Today, this would be standard of care. At the time, this was not standard of care. And did very well. He took his second dose, was still doing very well. This was in March. And then in April, he showed up at the emergency room with shortness of breath. He had 48% oxygen saturation. This is a chest X-ray. He was diagnosed with pneumonitis. He was treated with IV Cilimidrol, high-dose steroids, and ended up being released at some point as pneumonitis was controlled, and he did well, so he continued on his therapy. This was April. A couple of weeks later in May, he came back, and he actually had lost over 10 pounds. He was having 12 bowel movements a day. And this is a picture of a biopsy of his colon. All these little black dots you see are T cells infiltrating his colon. And at this point, he was diagnosed with colitis. Again, they tried with steroids, they tried with different drugs. One is called infliximab. It's a drug we use for inflammatory bowel disease, and it just didn't work. It couldn't control the colitis. And at this point, David didn't leave the hospital. 2 weeks later, David couldn't lift his head and he couldn't lift his arms. The immune system actually attacked his nerves. And at this point, he asked his care team, please learn from me. Regardless of what happened, please learn what happened to me and try to see if you can help the next generation of patients. And so we did. Unfortunately, David was intubated a few days later and passed away a few days later. When we did the autopsy, there was not a single cancer cell left. The checkpoint inhibitor therapy actually worked. But we could find these fighters, these T cells, in his colon, around his nerves. So clearly, we had unleashed the immune system at a whole new scale that triggered these side effects. We also find some of these bacteria that I'm listing here. We find these bacteria often when we deal with patients that are going through a bone marrow transplant that are heavily immunosuppressed, which means we had immunosuppressed David too much. There's a lot of things we learned from David's case, including that we really need a multidisciplinary team to care for David. An oncologist doesn't know how to deal with the colon or the lung or nerves. You need different specialists. We also learned that we need better treatment solutions from this and that we needed to do more research. So many questions here. David had 3 different IREs for immune-related adverse events while responding to this therapy. Why is that? Were these toxicity related to his tumor response? We can ask, were these 3 different toxicity related to each other? Was it the same biology between the colon, the nerve, and the lung? Why is it that the immunosuppression in the lung worked, but the same didn't work for the colon and the nerve? Could we have used a different treatment solution to help David while sparing the anti-tumor response? And you can ask, is David a unique case? I want to reassure you, this was a case several years ago in 2016. We're doing much better. We manage better, we've built a team. I'm going to tell you more about the team, so nothing to be afraid about per se. But David is not a unique case. I also got into this for personal reason. I have family members that have toxicity, very severe toxicity. And I thought I had the type of expertise I'm going to tell you more about in a few slides that could help with this. And so these are not unique cases. I'm showing you here in this bar graph the number of patients within the system, a medical system where I work at Mass General Brigham Hospital, that are treated as part of standard of care with these checkpoint inhibitor therapy. So we're well over 4,000 patients by now. Depending on the dose and the combination, whether you're just on PD-1 or combination therapy that would be targeting CTLA-4 PD-1, for example, you can, up to 90% will develop any tox that can be like simple skin rash, so low grade, and up to 50% will develop severe toxicity that may require some forms of hospitalization. And again, this goes beyond melanoma. Now, what you have to know, I told you there's over 109 indications approved for these drugs. Close to 50% of cancer patients in the US are eligible for these drugs as part of standard of care. And that these numbers don't include new clinical trials. It don't include all the combination therapies. It doesn't include the numbers of patients that are going on adjuvant and neoadjuvant settings. And of course, when you're in adjuvant settings, your maintenance therapy, I fully understand that the consideration of risk to benefit ratio, if you clear your cancer, is a whole different story. Do you really want to risk in developing some of these toxicities? These are important questions to have, important questions to ask, and important discussions to have. And if we can find solutions to mitigate these IREs, it opens a whole new world when you think about treatment solution. You can ask, what about prevalence? We were not hearing so much about IREs a few years ago. Should know that chronic toxicities are more prevalent than previously recognized. The chronic immune-related adverse events are defined as those that persist for more than 12 weeks or 3 months after the discontinuation of your treatment. And it can occur in up to 43% of the patients, and I have the reference at the bottom right. These slides will be distributed, and there's a recording, so you'll be able to take all your time to read all of this information. Why is the lack of IRA recognized? Well, you need to keep in mind that some of these acute toxicity can be resolved very quickly with steroids, so sometimes we just don't capture these events when we look at the incidence. The very early reports of trials focus most on the frequent immune-related adverse events, so when you deal with low frequency yet severe toxicity like myocarditis, we often are dealing with underreporting and under-recognized. And we need to look at their aggregate prevalence. The initial clinical trials enrolled patients that were metastatic, that are characterized with chronic and long-term events. It's really challenging to track these toxicities because of limited expectancy, which really constrain our long-term follow-up looking at these toxicity. And also, many patients have multiple comorbidities, and so it becomes difficult to know if this is actually a toxicity to the drug or due to something else. And finally, until recently, and I have extra slides if you're curious about this, or can find me later today to discuss this, until last October, we didn't have an International Classification of Disease code, ICD code, which is our common lexicon within clinic and research to describe disease toxicity. What is ICD code? When you go to the clinic, your doctor orders a test. He asks for insurance billing. You need a code that describes this event. And there's a whole path to developing ICD codes, and this didn't exist until very recently. You may ask, I want to know more about this. What's the kinetics of it? So most of these toxicities occur within 6 months of treatment initiation. Combination therapy is obviously more toxic than monotherapy. Skin is the most common. I'm showing you some of the dynamics here. Skin tends to happen first, followed by liver and some diarrhea. It doesn't mean patients are going to get all of them. Toxicities incidence will vary across the checkpoint use. So for example, colitis and hypophysitis are more common if you are on a drug that targets CTLA-4 versus thyroiditis. That's more common in patients that are on anti-PD-1. Some toxicity will fail to resolve. Why is that? So you can imagine if you have inflammation to your joint, once there's no more immune cells around your joints, you're back to normal, right? You can proceed. But in the case of the inflammation or these toxicities attacking some of your endocrine organs, like your thyroid, like your pancreas, you get irreversible damage because the tissue is destroyed, in which case there are solutions. You can go into hormonal replacement therapy, but it's to give you a sense that it's important to capture these toxicities as soon as we can because we can prevent some of these irreversible damage if we catch them on time. So what do we need? What we need is to be able to rapidly diagnose a patient with toxicity when you come to the clinic. When patients come in the clinic, sometimes it's actually hard to know if we're dealing with opportunistic infection, cancer progression, or toxicity. We don't have good tools for that. It would be great if we could figure out who's at risk for developing toxicity and which toxicity ahead of time, because we could change the treatment course. We don't know that. We also need better targeted therapy. I'm going to show you a few slides, and they're very generalized, but a lot of our treatment solutions are tied to using steroids that can actually affect your anti-tumor immune response. We really need partnerships with all of you, with the patient community, because the reality of it is that mouse treated with these drugs do not develop these side effects. These drugs were discovered in mouse, and there are certain models like vitiligo you can develop in mouse, but most side effects are not well recapitulated in mouse. So we actually need to work in partnerships with patients and their family to be able to understand the root cause of these toxicity. The following slide is very generalized. There's actually guidelines for every organ system involved with toxicity, but I want to give you a sense that across different grades, and I'm only showing grade 1 to 4, the 5th grade being fatality, to give you a sense that grade 1 and 2 we can manage in outpatient setting, and 3, and for you're hospitalized. For most part, it's the forms of steroids. Of course, there's other now treatment solutions emerging. And in some cases, we actually have to hold. And when it's very severe toxicity, we actually have to discontinue. And there's a whole question about if we can re-challenge patients, and it's also a subject of research. So we really need better treatment solutions that go beyond this. Better treatment solutions starts with understanding mechanisms. I realize it's a busy slide. The only goal of my slides here is to tell you that it's not a single mechanism. I told you they affect every organ system, from skin, heart, liver, lung, brain. And so it shouldn't come as a surprise that it's not a one-size-fits-all solution in terms of mechanisms. And there's, a good dozen type of mechanisms that are emerging from early studies, which suggest that it won't be a single solution to managing toxicity, and there's really a need to dig deeper into this. The other challenge is that some of these toxicities are likely tied to your factors that are tied to your tumor, and some are likely tied to non-tumor effect. And it's important to decouple them. Often I get the question, so if I have side effects, does it mean that I'm responding to my treatment? In some cases, yes. For example, skin rash often is tied to it, or vitiligo definitely tied to it. In some other cases, no. We also have patients that don't respond and have a toxicity. And so it's really important for us on the science side to try to figure out that if the toxicity is driven by factors that are tied to your tumor, whether it's an antigen, whether it's the genetics of the tumor, or if it's non-tumor related. Because the ultimate goal is to try to find therapeutic targets that would keep you on your life-saving therapy while we mitigate the toxicity. So we want to decouple both biology if we can. So what we've been doing at MGA is just try to map out what would be needed to solve this. So I'm going to show you a little bit what we've been doing. So we first set up infrastructure and expert knowledge for patient identification and patient care. Through my example with David, I show you that you need a multidisciplinary team to care for patients. I'm going to show you how we're getting organized to gather and develop and share expertise to care for patients and to connect. And then we've been setting up infrastructure in the inpatient and outpatient settings to partner with patients and their family and collect samples at the time of their diagnosis or their toxicity so we can try to figure out what's happening in their tissue and define new therapeutic targets. And we're analyzing these tissues using cutting-edge technologies, which I'm going to try to cover. So here's part of my family picture that I'm very proud of. My partner in crime is Dr. Carrie Reynolds. She's the director of the inpatient cancer unit at MGH. And together, back in October 2017, we dreamed up this family picture, which we call the Severe Immunotherapy Complications Service, and I'm going to show you in later slides the translational program. Every line of this wheel is a different expertise. So here mix are actually our melanoma team. Dr. Sullivan and Dr. Villani are also here at the meeting. We have GI, we have breast, we have lung malignancy, and they take turns in the inpatient setting to round an identified patient with toxicity that have been hospitalized, because they actually don't end up being hospitalized on the same floor, so we need a service of people that can identify where these patients are. Then, depending on the diagnosis that is made, they involve the right specialists, and so all other lines are actually specialists of medicine that are dedicating part of the clinic to care for these patients, whether it's gastroenterology, pulmonary, cardiology, every line is one of these people, these specialists. We set up operation in the inpatient setting, which is the wheel of care that I just showed you. We set up outpatient clinic so patient can come, coordinate with their oncologist to get specialized care. And Mass General Brigham has an extensive network, so we also set up some referrals across our network. And we're getting, if you're curious, I'm going to lift this up, we're getting a lot of requests for feedback and guidance, so we actually set up a second opinion. So you can all reach out and get second opinion if needed. And I'm going to leave the QR code for a second. There's more information about adverse events and solutions on this website. And again, you're going to get these slides later on. Beyond the clinical team, what we've been doing is build a team of over 20 scientists that includes, half of them are actually physician scientists in training across different divisions of medicine, whether it's gastroenterology, rheumatology, pulmonary, nephrology, and so forth, that we're training to care for cancer patients with these toxicities. So they bridge between the lab under me and the clinic and caring for these patients and studying them. The whole team has been publishing a fair amount of papers to try to better understand the presentation of these toxicities so we can try to better classify patients. So we have a patient-centric effort between the oncology team, the wheel of care, and my team. We also team up with surgical team, nursing team, the melanoma biobanking group, and rapid autopsy program, through which we had a chance to learn a lot from David. I'm going to show you an example of how we've integrated our research team through the clinical care. So we collect as part of clinical care. We don't collect as part of clinical trial, so it takes a whole different type of roadmap to do this. So we had a metastatic cancer patient, 63-year-old. She was treated with pembrolizumab, and she showed up, and she had muscle weakness. Dr. Cohen was her oncologist. She reached out to Dr. Goudon. She's a neuromuscular expert, and Dr. Goudon recommended that we do a muscle biopsy. Muscle biopsy went to pathology, and part of it went to my lab for analysis, of course, with patient consent. And Dr. Fisher-Thomas, who was also a gastroenterologist at the time, led some of the experimental effort. And we also got blood with the muscle biopsy. Overnight, the patient's knee swollen, so we actually had to reach out to Dr. Schlenfeld, who's a rheumatologist of the team, who came and took some infusions of the knee. Some of it went to pathology, some of it went to my lab, along with pair blood. Patients got diagnosed with acute polyarthritis. We analyzed the synovial fluid in the blood, along with the muscle biopsy. A patient got diagnosed with myasthenia, myopathic overlap with arthritis, got treated with steroids, did well, got discharged. It took only this is sarcasm, only 60 email communication to make this happen, collect samples from one patient, but we did it. It was a success. We learned from this patient. We figured out that some of the biology was shared between the joints and the muscle. We've now collected samples from over 400 patients through this type of coordinated effort across different organ systems, and we're trying to learn about what's driving this toxicity. And so what we're trying to figure out is whether the biology that's driving inflammation to the colon, to the heart, to the liver, is it the same? Because if it's the same, then we should be treating it the same way. But if it's not the same, then we need to treat it differently. What we're trying to do is figure out what are the bad cells driving it. So that's what I call exploring scale. Then we try to explore time. Because when you do human studies, what you want to do is you want to try to figure out if there's a specific component. It could be a cell, it could be a protein, or factors that track with diagnosis, and that disappears when you give steroids. So what you want to do when a patient is diagnosed before steroids with patient consent is we collect tissue that is affected with blood and serum because we want to try to understand how this is captured in the blood. And then through amazing partnerships with biobanking, we actually have access to pre-treatment samples, and we collect until resolution or relapse. And then we do a slew of measurements. The workhorse is a new technology, new-ish technology called single-cell genomics, and the best way that I can describe it is through my fruit salad analogy. So the fruit salad here is supposed to represent a skin biopsy where every piece of the fruit is a different cell type. And so historically, the way we've been analyzing the content of a biopsy, whether it's skin or heart or liver, it would be the equivalent of doing a fruit smoothie of all of the fruits in the cell. So we'd be taking the average of all the cells. This is not very practical, because let's say you only have 3 bad cells, 3 pathogenic cells. How are you supposed to find them? These single-cell genomics technologies enables us to kind of look at one cell at a time, figure out the makeup of it. It's the equivalent of flipping the fruit salad on the table and organizing all your fruits. And then you can even count the number of fruits you have per type of fruit. But you get even more information. It's not enough to say that there's apples. There's actually many different types of apples. So even if you have, like I'm telling you, these fighters, these T cells, there's many different types of T cells the same way there's many different types of apples. Some apples are good for, I'm not very good with examples for cooking, but like maybe a pie, and then maybe you want to do a sauce for a stew. The same thing for your cells. Not only that, maybe within like Macintosh apple, there's some that are very good and juicy, and some might be a little dry, and some might be profoundly rotten. It's the same thing for your cells. I need to be able to figure out if the cells are healthy and ready to fight, or if they're really dry and rotten, and they kind of need to be reinvigorated. So with the technology that we're using, we can do this. We can figure out every single cell that is in the tissue that is affected, and we can figure out which cells is a good cell and which cell is like a bad cell that we need to be therapeutically targeted. This is the power of single-cell genomics. So what we take the biopsy, we make a single-cell suspension, and these little cells here, the colors are like the equivalent of the different fruits I would have in my fruit salad. And then we have this technology where we can extract the genomic information of every cell one at a time, we at high speed. And then computationally, it's like flipping the bowl of fruits on the table. We can computationally figure out all the cells that are there. We look at the features that we're measuring. And then we can regroup the cells based on shared feature. That can be in the RNA, DNA space, protein space. And then we can regroup them based on those that are similar to each other. And then we can find those that are only in the cases, the bad cells. And this is how we can get hints about pathogenic cells and drug targets. So what we're doing is we're taking the biopsies of the affected tissue, it could be the heart, the lung, the liver, as part of standard of care, and we try to figure out what are the bad cells in there. Then in some cases, we also have access to the tumor. And so that we can ask, are the bad cells in the tumor and in the toxicity lesion in the blood, is it the same or not? Because I'm trying to find drug targets that would be specific to the organ with toxicity. And then for anything that I find in the organ affected with toxicity, ask if I find it in the blood, because I'm trying to find new biomarkers so I could predict who's at risk for toxicity. And so a few months ago, we published some of our findings in a journal called Nature. We did our first analysis of myocarditis. It's the most fatal toxicity. 50% of cancer patients that will develop myocarditis will unfortunately pass away, so we really need to do better. We showed that the biology that is related to anti-tumor response is different from the heart, which really gives new hope in being able to decouple both of them. We found some factors in the blood that could predict if a patient would die. That needs to be validated in a bigger cohort, but actually gives some hope. And we can use our data to try to identify potential therapeutic targets. And some of it is already happening. Some work was already happening in parallel and are finding further support in the ongoing clinical trial that use abatacept for trying to treat a myocarditis. This was sponsored through MGB in partnership with BMS, and this is currently ongoing. This is first trial of that scale being done for toxicity. We also publish, so our work is starting to be published now. We also published last year, and a lot of it was supported by MRA. Our work on checkpoint colitis, we defined some of the biology driving checkpoint colitis. We also nominated new therapeutic targets that could decouple the tumor and the colon inflammation that we need to follow up upon. But these little maps that I'm showing you are maps of these cells that we found in the tissue. We have ongoing efforts in the liver, the joints, the CSF. Nephritis is inflammation of your kidney, and different endocrinopathies, using the same approach. Because we're doing it across all organ system, it means we can bring all the data together and start asking, are these toxicity created equally? Is it the same biology? Should you be treating the same way? Is it related to the tumor? Can I predict it long term? Obviously, this is done at small scale, and we need to do it large scale. But this work is really important in terms of setting the next phase. And so I'm really proud of this grassroots initiative. They may look like we're top-down funded. This is completely grassroots. People like drinking the Kool-Aid and believing that it's not enough to cure people. We need to give them quality of life. And so I believe that with this big type of data approach, we can define therapeutic targets that could be followed up in clinical trials in years to come. I'm gonna finish with like quick notes about like what's needed. We need you. Like this needs to be done in partnerships with patients and their family. We need larger cohorts to figure this out. We also need to be able to bank samples, which is not cheap. We also need to be able to collect samples in partnership with you and your family across time points so we can define these predictors and these biomarkers. We need to be able to define better lexicon so we can distinguish treatment response from toxicity. And actually funding is very challenging. Of course, everybody is really eager for the next therapy for improving efficacy. Toxicity is not sexy, but actually toxicity is one way of making treatment better. And it's actually really hard to fund these clinical trials and to fund this type of research. It takes a village to do this, whether it's on this is meant to be like it's on the clinical side, it's on the type of big data approach that I'm doing, it's with partnerships with our clinical colleagues, defining better models so we can test new drugs. There's a lot to be done. So in conclusion, remember, this is a good news story. I know it's scary to talk about these side effects. It's important to be aware of them because the sooner you can tell your oncologists, your care providers, that you think you may have some symptoms, the better it is, because the sooner we catch it, the easier it is to reverse. The problem is when we let it go for too long, then it's really hard to reverse. I really keep in mind that the checkpoints are the backbone of future combination therapy, and I actually personally believe that part of future of improving efficacy is by mitigating these side effects so that we can keep patients longer and safely on these drugs. And so here's my last point. I need your help because there's a lot of advocate here, and it's actually very hard to fundraise for this. I'm incredibly grateful for MRA for having funded this work. But we need your voice so that people know that this needs to be funded. It's not that you can ask who picks the bill. It's not that pharma doesn't care. Of course, everybody has different priorities. We need to think about the next drug. It's not that private foundation don't care. Of course, they care. MRA has funded this, but this needs to be done at a whole new level in terms of scale. And there's all sort of challenges with government funding. So definitely need your help in terms of voicing the importance of studying these side effects. And so I'm around today. I'm going to be at the event tonight. So if you want to hear more, come and find me. This takes a village to do this. I mostly want to do a big shout out to Dr. Kerry Reynolds, who's my partner in crime, in setting this whole endeavor. MRA for really believing in this very early on. And most importantly, all of you and your family for partnering with us in this journey. Without you, none of this would be possible. Thank you for your attention.
All right. Can you all hear me? We have one quick question over here. I'm in the back, this way, to your left. All right.
Hi, I'm Kevin from A Cure Insight. I live in Philadelphia, and thanks very much. That was a great talk. This is one of the biggest unmet needs in the treatment of patients with advanced cancers, is trying to find a way to defeat these immune-related adverse events. So congratulations on all your hard work. I just wanted to ask you real quick, two other fields for inflammatory research. Are you familiar with inflammasomes, the
Sure.
NLRP3? Is this a line of investigation for you guys?
So the way we're analyzing the data is in an unbiased way. So, if the inflammasome comes and says hello, I'm going to say hello back. Actually, part of my PhD was in the inflammasome. So I definitely would recognize if NALP3 would kind of come and speak to me. I can tell you that when it comes for some of these sensing pathway, we can see it when we have a lot of tissue damage, like in the colitis. In some case, you would see it. I think what's interesting is that even when you look at within one organ system, I showed this slide with all these mechanisms. Even within one organ system, the mechanisms are not uniform. So so inflammasome, I could see some signaling in some patient, but definitely not in all.
And one other pathway, it's called ROR gamma T. Is that also of interest or possibly indicted in immune-related adverse events?
So we haven't seen a lot of ROR gamma T showing up, but there could be many reasons for that. Some of it can just be a question of power of sampling. We need to kind of do these analyses more at scale with bigger cohorts. So the way we did these initial studies, because of a limited amount of resources, is that we were very strict in our inclusion and exclusion criteria. We included patients that had the most severe toxicity, that were not on other therapy, hadn't received steroids, so these sample size are small-ish in terms of 40, 50. As we increase the number of patients, once we found more resources, I suspect we would see more heterogeneity in the mechanism. I'll give you an example. For example, in lung, if you have pneumonitis that is secondary to lung malignancy, it will be an autoreactive T cell, so cells that are attacking the tumor and the lung. It's a shared antigen. If you have pneumonitis secondary to melanoma, it doesn't look like the pneumonitis due to tied to the cancer. It actually looked like a resident memory T cell. These are cells. So you have some of your fighter that stays in the organ that are there to kind of do quick pathogen recognition. So the mechanism is actually different. So I suspect that as we analyze larger cohorts of patients, we'll be able to better stratify patients, and that will really help in tailoring treatment. But there's a lot of work to do ahead, but some of the results that are emerging from our work, partially funded by MRA, shows that this is actually possible with the technology that I've shown you. And so it's very, it's with this partnership, this is actually possible.